What a wonderful talk, Dr. Espinosa. And so Spain is doing it, Madrid is doing it, Barcelona is doing it,
Yeah.
Argentina and Chile are doing it too.
Argentina, Chile, and Mexico.
And Mexico. Colombia is doing it. United States have to do it too. Yeah, similar to time to TPA, time to seizure medication. And I think that we're going to be seeing some of these changes in the next years.
Yeah.
Wonderful. I'm going to have the questions at the end. I have lots of questions already, but hopefully you guys too. And then we're going to continue with my topic. We'll talk about acute symptomatic seizures. We'll discuss what we know and what is next. And into the what is next, we're going to discuss about 4 years or 5 years work that we have been doing with a group called the Post-Acute Symptomatic Seizure Investigation and Outcome Network, which is like 5 institutions that have been working into developing guidelines, treatment for patients that had acute symptomatic seizures. There you go. These are my disclosures, which none of them are associated with a, thank you, with a time that, oh yeah, the time, yeah. Total time. Forgot about this, thank you. Put my time so I don't talk too much. I tend to talk a lot, actually, when I like something. I get passionate about it. It's my Latino part, and my hands go up and down. And then my watch says, are you doing your exercise? Like, I'm just moving my hands. Perfect. So we're going to start with a case. It's a pretty common case that we all get called to the emergency department. Probably not 27-year-old patient, but a patient that is brought to the ER because of altered mental status and had a tonic-clonic seizure. The patient was just recently hospitalized due to MSSA bacteremia that complicated with a DVT for what she had to be in a peak 7. And the patient is admitted, and the CAT scan has been done. As you can see, she had a fairly large 25 almost cc's left frontal ICH with some cortical involvement. So the patient in the ER gets loaded with levetiracetam and gets started on anti-seizure medication. They did a workup to find the etiology, if there's any underlying vascular abnormality or any tumors, and it all is negative. The patient is admitted to a neuro ICU, remains with altered mental status. And I asked the audience, should we start EEG on this patient? I don't hear. Yes, thank you so much. We should. I agree with you 100%. Unfortunately, this patient was not started on EEG until the second day of hospitalization. That's a lesson to be learned at my institution. They heard about it when I heard about this case. But on the second day of admission, they put her on EEG, and then as soon as they put the EEG, the patient had 2 focals, frontal seizures. One of these seizures lasted almost 12 minutes. 12 minutes is almost a status epilepticus, so for just 19 seconds is not a definition. I'll call this a status epilepticus. And the second was 4 minutes. And this patient was, of course, treated. She was increased the dose. They was given lorazepam and increased the dose of levetiracetam. So this patient indeed had what is called an acute symptomatic seizure. That another synonymous for this type of seizures is provoked seizure, reactive seizure, situation-related seizures. And we had this definition by Beggy and the colleagues about like 14 years ago, when they defined that acute symptomatic seizures is defined as a clinical seizure occurring at the time of a systemic insult or in close temporal association with a documented brain insult. And brain insult can be structural and non-structural, such as toxic metabolic or infections. Here they define it as a clinical seizure, and we talk about it in a little bit more. For each of the etiologies, there's a time frame which it was considered to be acute symptomatic seizure. For the structural brain injuries, such as stroke, TBI, traumatic brain injury, the suggestion was within a week of its presentation. From non-traumatic subdural hematoma was upon the presentation. From CNS infections can actually be more than 7 days if there's still some clinical or imaging data that can support that ongoing infection. For example, tuberculous meningitis can be up to 14 days. For neuroinflammatory disease, it can be on the time of the presentation when it gets diagnosed as a patient or when they have a flare. And then with severe metabolic derangements is within 24 hours of the specific biochemical or hematologic abnormalities. And what is the impact of these acute symptomatic seizures? I'm going to call it ASIS after this. So the impact of this ASIS is that once it presents, has a high tendency of recurrence. So the patient can tend to have multiple ASIS during the same hospitalization. These are associated highly with mortality within the 31st day after its presentation, up to 20%, and is higher in elderly and also higher in a stroke and an oxy brain injury. And the mortality risk is significantly higher after an unprovoked seizure. So when you compare provoked seizure or ACEs with an unprovoked seizure, the ACEs have significantly higher mortality, which is almost like 9-fold. But the question always remains, right? What is the risk of the secondary unprovoked seizure? What is the long risk of epileptogenesis in these patients? So Hazardov and his colleagues in 2009 followed patients with diverse brain injury etiology and compare the provoked seizure patients with unprovoked seizure patients and see up to 10 years what was the risk, the cumulative incidence of having unprovoked seizures in the future, meaning having epilepsy in the future. The green line is unprovoked seizure patients, the red line is provoked seizure patients. And the cumulative risk up to 10 years for the provoked, so the ACEs, is 20%, and for the unprovoked is about like 65%, 60%. Hence why the definition of epilepsy is with a recurrence risk of 60% or more. But then within the provoked seizures, the ones that present with status epilepticus, those have higher risk of having epilepsy in the long term, which is a 3-fold of them. And these are clinical data. But now we know that over the last 2 decades, EEG has been used widely. And we know because seizures, electrographic seizures, are a common complication of critical ill patients, not only with brain injury. And I want to call this also ACEs, electrographic ACEs, which was not part of PEGI's definition, but it's important because now we have acknowledged this and discovered more of this complication for these patients. And we don't only have electrographic seizures, right? We also have these periodic patterns that we didn't know what to do with them, like 2 decades ago, and Dr. Maciel here present, Dr. Stroh has done a lot of research in this matter, and we have seen that some of these repetitive periodic patterns, when they discuss a follow-up, can have actually a risk of potentially ictal risk. And those, we have finally in 2021 defined what is the ictal interictal continuum. So things get more complicated when we have an EEG now when we follow these patients. So let's talk about management. What do we know about management for ACEs patients? First of all, I want to establish a definition of what is primary prophylaxis and secondary prophylaxis, because it's very important for us to acknowledge and know this as we read literature in the past and in the future. So primary prophylaxis, as you can see in the, how do you put that? Oh, there you go, is when the patient had a brain injury and has not had any seizures. These are seizures, has not had seizures. So you put primary prophylaxis to prevent ACEs occur because we know associated with high mortality. And secondary prophylaxis is when you have given medication to a patient that already has an ACEs to prevent recurrence of it. Okay? We know that primary prophylaxis has only been favored to decrease recurrence of ACEs, not recurrence of epilepsy or epileptogenesis in traumatic brain injury patients. So for those ones, we know that we at least give 7 days. For moderate to severe TBI patients, we give 7 days to either phenytoin or levetiracetam. Nowadays, we're away from phenytoin because more messy drugs, and levetiracetam has like less interactions. So forget about primary prophylaxis, but I want to put that there. Let's talk about what do we do with secondary prophylaxis, or what are the recommendations in prophylaxis in general, because it's going to get a bit messy when I go into depth on these things during the hospitalizations. So what do we know in the past, right, is that there's a lot of challenges in managing in-hospital ACEs. One of the challenges is because patients get admitted to various services. They're going to be in the cardiac ICU, surgical ICU, medical ICU, and not always a neurologist is going to be following these patients, right? We know that by the NYU data. The assumption is that we have to treat these patients following the status epilepticus algorithm or regimen, and perhaps that's not the best regimen to follow. And because we also lack of original research, and there's inconsistent guidelines, recommendations on how to treat these patients. What do our guidelines say? The European guideline for ischemic stroke suggests that we should not continue seizure medications after the patient has had an ACEs. So no secondary prophylaxis. The American ischemic stroke says that recurrence of seizures is quite high, so perhaps secondary prophylaxis should be given, but they don't tell us how long do we have to give it. The ICH guidelines for the AHA tell us that also secondary prophylaxis for ICH should be given, but it not tell us for the time being. And with the other type of intracranial, but not intracerebral, hemorrhage, subarachnoid hemorrhage, it tells us that if a patient has an ACEs, reason is to give 7 days of treatment and then stop, because there's not good data to support prolonged time of seizure medications. And they talk about 3 different references, but because of the time, I'm only going to talk about one of the references and extrapolate in all of them. You know how I say about primary prophylaxis, secondary prophylaxis? So the reference that they use for the guidelines, one of them, which is reference 410, is a meta-analysis that included 5 different studies, and in each of them, of these studies, all patients with suprarenal hemorrhage, all patients with suprarenal hemorrhage, all patients with hemorrhage were used seizure medication. So this was primary prophylaxis reference, and they using that reference to create a secondary prophylaxis recommendation. That's what I said, we lack in original data. We don't have original data to talk about secondary prophylaxis measurement, treatment for these patients. In one of our reviews with experts about ACEs, what they recommend about management is pretty much you have to know what is the etiology of the patients causing the seizure so you can treat it as soon as possible. The treatment should be individualized, try to treat the severity of the seizures, patient clinical status, and also look into patient comorbidity. And then they mention about the optimal seizure medication length. It's really uncertain. They say that possible for any structural etiologies, 1 to 2 weeks is probably effective, and there is lack of data or benefits into the prolonged therapy comparing with adverse effects of these patients. So there's a lot of uncertainty right now in the hospital management, as you can see. Let's talk about discharge. What happened with these patients? So the patients come to us, have the ACEs, we start him on seizure medications, and then what do? So we know by 3 different large studies, 2 that were single center and 1 was multi-center by 3 big centers, that the majority of these patients that get clinical ACEs and on continuous EEG, they get discharged on seizure medication. Between 66% by the NYU data to almost 100% by the multi-center data. And they get discharged on seizure medication, and then who follow these patients in order to make sure that the seizure medication is appropriate to continue, or should we stop these medications, prevent polypharmacy. Most of these patients are 65 years of age and above, and they have multiple medications that are going to take. And this medication can also have side effects. So knowing this lack and critical lack of knowledge, we create, and is with Dr. Aditya Siravaju from Yale, Vineet Punia for Cleveland Clinic, Sahar from MGH, and Dr. Nishay from Ayub from Brown, and myself. We create a post-acute symptomatic seizure investigation and outcome network. This is a structural model of post-ICU follow-up patients. We can follow up these patients that have had the first ACEs, right? They have an ACEs, they were admitted to the hospital, had an EEG or not, and they were discharged home with seizure medication. So we have an alarm, and we stratify these patients to be followed for us, so someone can actually take care of these patients into education about what is unprovoked seizure and give education for first aid. There's a lot of comorbidities about that, and that's a different topic in its own. Or also continuation of this seizure medication, appropriate dose or different medication, or to stop these medications. So now we're going to shift to what is next, because this is our work that we have been doing for the last 5 years. One of the first things that we did as a group in the consortium is we create a big survey to understand real-world data and to what our colleagues do with the management of these patients in hospital discharge. About 502 responders we had worldwide. The majority, or I guess 2/3, were from America, United States, because America is very large. We also have Colombia, is also in America. It's not the United States. And we asked them, it's a survey based on a case. A patient came with an intracerebral hemorrhage, had a seizure, and then the patient was loaded with seizure medication. Will you continue? 95% said yes. We'll continue with levetiracetam as it was this case. Will you discharge the patient on seizure medication? 84%, so most of us, despite all the guidelines I just mentioned, right, said yes, let's continue on the patient with seizure medication. How long will you continue this patient with seizure medication? So about 70% of them continue up to 6 months, and then the rest will continue up to more than 1 year of data of seizure medication. We also look into our own institutions. We had almost 2,000 patients, of one of them 900 that were alive by the time that we did analysis, and look into what is also our outpatient management for seizure medication. We saw that about the 922 patients that were alive at discharge, 31% of them were discharged on seizure medication. That electrographic seizures had a lot more of this. Patients with electrographic seizure had a lot more of incidence of discharge of seizure medication than patients with clinical seizures. We also saw that 60% of patients with LPDS, so lateralized periodic discharges or lateralized rhythmic delta activity, were discharged on seizure medication. And it still was about 10% of patients without anything on EEG, no clinical seizures, no radiographic seizures, were still discharged on seizure medication just because of primary prophylaxis. And we ask, right, why are we having increase of seizure medication at hospital discharge? Despite not having any good anti-epileptogenesis potential in these medications, why are they still continue on these seizure medications up to sometimes 2 years discharge? And this is data from the epilepsy world, in which Marson and his colleague, about in 2005, 20 years ago now, when they did a randomized trial with patients with unprovoked seizure, they came to the ER and they randomized to 2 arms. The FAIR seizure medication and the continuous seizure medication. And they followed these patients up to 2 years. And the ones that were the FAIR is the blue line. The one that is red is the immediate seizure medication management. And as you can see, after 2 years, there was some benefit in start immediately with seizure medication. And this benefit was actually larger, a bigger delta, as you can see. In the next slide, I don't know what I'm pointing out. See, I'm talking with my hands. Here it is. And you can see in the second one that this actually benefit was a little bit wider in the patients that come with multiple seizure representation, right? And then you can say, what did I say about a CIS? Highly recurrence, right? If anybody reads EEG, how many times you guys have seen a patient with just one isolated electrographic seizure? It's pretty uncommon, right? Most time I have 1, have 2, have 3. So most of the times, patients are actually in the multiple seizure presentation. So this is potentially why they actually discharge on seizure medication and get at home. But let's not forget that when you compare unprovoked unprovoked with a CIS, the gap is quite wide, right? The cumulative incidence of epileptogenesis for a CIS is much, much smaller than the one with the unprovoked ones. Now, we look into the factors associated with continuation of seizure medications in a CIS, and the lines in red are the ones that were factors that were associated with seizure medication treatment in the hospital, and etiology was one of the driving factors. Having a structural brain injury or having a progressive brain injury was a factor. The location in the hospital, whether the patient was under the neurology team or it was in the ICU, was a factor for these patients to be started on seizure medication. And also the electrographic findings. We look into also seizure medication prescription at discharge, and is the blue line. And then also etiology, the same one, location, electrographic findings, and also a Glasgow Alchemy scale better than 2 was factors associated for what in our centers patients get discharged on seizure medication. What about the outpatient management from ACIS? So this is some data that we already have submitted for publications, and it's under review right now. But what we have analyzed in our post-acute symptomatic seizure clinic patients is that when we compare seizure medication discontinuation, and then as a competing factors, we have death and unprovoked seizures, our patients that are followed in our post-acute symptomatic seizure clinic, they have a higher rate of seizure medication discontinuation in a very safe way, because the unprovoked seizure recurrence is quite low. It's about 20% up to 36 months. And the first seizure medication discontinuation was up to 30%. So a third of our patients were stopped seizure medication. When we talk about stop seizure medication, was if the patient was in more than one, is if we stop at least one of them. And if it wasn't one, of course, that we stop the seizure medication. And then we also look into the cumulative incident percentage of patients who had an unprovoked seizure, competing with death. And then up to 36 of follow-up, of all our patients, about 23% of them had unprovoked seizures, but 15% of them had within the first year. Again, this is also a small sample of the patients that had recurrent seizures or epilepsy after ACIS. So really, with less than 15% of patients having unprovoked seizure in the first month of follow-ups, our finding supports that individualization of seizure medication use, an approach effectively implemented through a structural outpatient model like the PATH clinic, is quite appropriate. So what do we do when we have these patients in the PATH clinic, and how do we make the decisions to discontinue seizure medications? We have 3 fundamental principles. The first one is we look into the underlying lesion to see the potential of epileptogenesis. The second, we look into the risk of progression of epilepsy based on what we know on the patient's brain injury etiology. And the third one, that it might be new to a lot of us, is the duration of these hyperexcitability biomarkers in the cortical activity of these patients. How do we do this in the post-acute symptomatic seizure? Something that we can also do it in other clinics when we follow these patients. So first of all, we look for the underlying lesion. I already mentioned. We have lesions that can be pretty much benign to lesions that can actually be more injury prone or more epileptogenic or hyperexcitability prone. Right? So you can see here, because I have 6 minutes. So the acute hyperexcitable ones, that are the ones benign, are the ones that can cause you a transient, most likely transient assis. That is, the hyperexcitability lasts from hours to few days, with the pathology resolving with the same time frame. So these pose the lowest risk of epilepsy. The subacute hyperexcitability ones are when the etiologies that cause you hyperexcitability that persist for days to about a week, with an underlying pathology resolving within a similar period, and this carries a low risk to epilepsy. And then we have the prolonged hyperexcitability etiologies. They are not reversible. They give you a brain injury, a scar tissue in the brain, and these conditions carry a higher epilepsy risk and require individualization assessment. So let's go back to our patient, 27-year-old patient, had an intracerebral hemorrhage, so it goes within the realm of the prolonged hyperexcitability. So what do we do next? The second fundamental step is we look into the risk of progressing to epilepsy. How do we do that? For different etiologies, we have different scores. We have a SELECT score to predict epilepsy in patients that have had ischemic stroke. We have the CAVE score to predict epilepsy in patients that have intracerebral hemorrhage, similar to the LANE score. We have the RISE score that look for epileptogenesis for suprarenal hemorrhage, the DIAS for cerebral senile venous thrombosis, and the PT nomogram for post-traumatic epilepsy. So we have scores that can actually help us predicting what is the risk of having epilepsy in these patients. So in our patient with the CAVE score, so she had cortical involvement, it's 1 point. She's 27 years of age, 1 point. The volume on the hematoma was more than 10 cc's, 1 point. And she had an acute clinical seizure, so it's 1 point. So she has 4 points, which it gives you up to like 46% risk of epilepsy. So it's quite high risk. But what about the EEG, right? Seizures are a neurophysiology pathology. We're just talking about clinical and imaging. EEG should play a role in this. In the past, we have known that EEGs can be a biomarker of predicting symptomatic epilepsy in these patients, and we have studies. One of them is for Dr. Struck, for the ICH patients, traumatic brain injury, ischemic stroke, but all this have been done with inpatient EEG data. So in the acute cerebral brain injury, when there's a lot of hyperexcitability because of the increase of glutamate as the brain wants to regenerate and not die. However, now we have data also from our group. This is from Dr. Sivaraju. There was a single-center study at Yale when they looked into his outpatient EEG data in the patients that he followed with a post-acute symptomatic seizure clinic, and they saw that persistence of epithelial abnormalities on follow-up EEG can give you an odds ratio of 7 to predict or to cause epilepsy. And also in our past group, we did the same, and then we saw that epithelial abnormalities on post-discharge EEG has a 5 risk of unprovoked seizures. So EEG is also a good biomarker, not only in the inpatient, but the outpatient care to see if these patients are going to have epilepsy or and should we continue with seizure medications or not. Normally, we do our EEGs within 3 months. Our patients are followed at 3 months of hospital discharge. The reason why is because we let our patients to go to rehabilitation and then come to our clinic and then avoid to have those high risk of having seizures just right after hospital discharge because they're recovering, and of course the conditioning in that moment after a seizure will be too hard. So we normally do like 3 months EEG in outpatient when we see in the past clinic. So back to our patient. So she had multiple acute symptomatic seizures, and I would say, and I think Erin agreed with me, she had electrographic status epilepticus. Her CAVE score was 4, so it gives you a 46 risk of epilepsy. We did a follow-up EEG. We normally do 60 minutes or more of EEG. There's no benefit of doing a whole, we don't know. I don't know. We don't know if there's a benefit of doing a whole day. So where 60 minutes is enough data collection, and for some of the study that Dr. Struck has done as how he discovered and produced to help to be a score. And that follow-up EEG showed intermittent left frontal slowing, so doesn't have epidermal abnormalities. And we discussed with the patient. We discussed with the patient into, this is your risk factors, right? She's a 27-year-old woman. She's thinking about pregnancy in the future. And we asked, like, you have quite a high risk of having epilepsy. And she decided to continue with seizure medication and then reassess it in a year from now. She was doing so well, she was recovering physically, that she didn't want to have any chance into having another seizure in that moment, knowing that her risk was a bit high. So we do a patient-centric approach, right? Based on these patient risk factors that we have decided to continue seizure medication and involving the patient as well. So what is for the future? So for the future, we need, it's great to do patient-centric approach, but sometimes it's hard and it's easier to just follow guidelines, right? And to make sure that we can all standardize the management of these patients. But then for this, what we need is also, we need to redefine ASIS. Beggy et al. Define ASIS as clinical seizures, and we know that electrographic also matter, and they are not uncommon. So we need to redefine ASIS by also using EEG data. We also need to have, as an outcome for our studies, non-seizure outcomes, and then this is something that we're proposing and thinking with the team. Should we do a 2 arms of duration, 3 months versus 12 months? Why 3 months versus 12 months? Because in the data that I just showed you from our clinic, we showed that up to 36 months, 23% of the patients had an unprovoked seizure, right? And so 23% in 36 months. But at 12 months, 14% of them had unprovoked seizures. So that's 50% of the total, 50% of the total patients that they had unprovoked seizures. And there's other data that also suggests that up to 2 years of follow-up, 32% had unprovoked seizures, 2 years of follow-up, and within the first month, 50% of the total patients had actually unprovoked seizures. And this was actually a month, but again, these patients might be in rehabilitation, and then having a seizure in that moment might be too much of a high risk. So we're thinking about, if we should do clinical trial, we should diversify 3 versus 12 months, and then medications stop. But then we are not having a patient with seizure medication for 2, 3, 4 years, as we have seen sometimes in the outpatient clinic. So as a conclusion, ASIS are a common complication of critical ill patients, and they're associated with mortality. So ASIS is not good, no bueno, está mal. We need better evidence for ASIS management in the acute phase of the underlying disease, and we need to use precision medicine. Until we have guidelines, we need to use precision medicine. Look into the underlying etiology, use the epilepsy risk scores, and then use the EEG, is our friend. It's a neurophysiology data that can give us prognostic markers as well. And then a structured outpatient care model works with a post-acute symptomatic seizure clinic, but that's something that's replicable in either clinic. When you have a patient as this one, you can follow these steps and also do the same care for this patient and minimize unnecessary seizure medication for these patients and provide education. And finally, a randomized controlled trial is needed, and hopefully we can propose and work together to create more guidelines that we can all follow up. With that, thank you so much.